the fact that the brain, much like the heart, is an electrical organ. Everybody kind of knows that the heart runs on electricity. The brain is exactly the same way. And in the same way that when we develop arrhythmias of the heart, which are abnormal electrical signals, and put in a pacemaker, the same thing can be thought of as Parkinson's disease or tremor or dystonia. Those are abnormal electrical rhythms. And if you can put a pacemaker into the brain, you can change those rhythms and you can have tremendous impacts in people's lives. So really, the way you can conceive of it is that deep brain stimulation is a brain pacemaker. So, go back. Oh, I see how it goes. Okay, great. So I'd like to start off with just a patient who's undergone deep brain stimulation for Parkinson's disease. I think seeing what this therapy can do in real time is a great way to start off a talk. There we go.
Very briefly, you were diagnosed with Parkinson's when?
17 years ago.
17 years ago, and you underwent bilateral ST&DBS
3 years and a half.
3.5 years ago. 3.25 years ago. Okay. Just going to examine you very closely.
So this patient has Parkinson's. The device is turned off but implanted. And you can see that this patient has all of the symptoms that we're here talking about today. It's got tremor, it's got dystonia, rigidity, bradykinesia,
and the lower extremity as well. Extreme rigidity. Extreme rigidity.
So we'll go ahead and we'll turn the devices on. And the devices generally are in the upper chest region with wires that go up and into the brain.
See that right side just relax right away. You can see that left side just... It's like a new man. It's like a different person.
So there's that same patient with the generators in their chest running a triathlon. And so what I said to you before, this is really a therapy that is designed for you to live a normal life. I was not, overestimating this. This is about getting you essentially back doing the things that you love. And so brain pacemakers really do represent a very new era for the treatment of neurological disorders. Historically speaking, we treat neurological disorders with drugs. This is a non-drug therapy. It is a completely new paradigm to treat your neurological conditions. All about improving the quality of your life, offering hope where medications fail you. And I always say to patients, it's not about getting you out of a nursing home. This isn't a last-ditch treatment. This is about getting you back on the golf course or getting you back on the tennis court or essentially... Oh, okay. Sorry about that. Yeah, there you go. Weddings. All right, fine. I'm glad you did that. Great. Okay, fine. So as I said, it's about getting you back to the weddings that you want to go to, essentially. So anyway, even though deep brain stimulation seems like this really sci-fi-like cutting-edge therapy, the use of electricity to treat neurological conditions actually has a really, really long history. About 45 AD in ancient Rome, there was a well-known physician by the name of Scribonius Largus. And he actually had a lot of patients that had pain due to what was presumed to be gout, which caused neuropathic pain of the leg. And, the therapies there were somewhat limited. And it was a frustrating disease because it really impacted the quality of people's lives. They became bedbound because the pain was so bad. They wouldn't go out into the Roman nightlife, if you will. And so one of his patients was walking along the river and stepped on an electrical torpedo fish, essentially an electrical eel, and got a huge shock in their leg. And the pain went away for hours. And he reported it back to Dr. Largus, and because there was no FDA around at that time, Dr. Largus went down to the riverbank, got a bunch of eels, and started shocking people, and actually would treat the pain that way. So this was the first use of electricity to treat a neurological condition. So today, DBS is essentially used for all different forms of movement disorders, Parkinson's disease, tremor, dystonia, and it has a full FDA approval. It's been FDA approved now for 18 years, something like that. And it's covered by all insurance carriers, including Medicare. So it's fully insurance approved, and there should be no issues regarding worries about that type of things in terms of a barrier for getting this life-changing treatment. For years, we only had one manufacturer of this. It was Medtronic. A few years back, Abbott, another multi-billion-dollar company, entered into the field, and then recently Boston Scientific. So now you have $3 billion companies in this field for the first time. That only means good news for all of you, because as the companies compete, more and more technologies come to bear. This therapy rapidly is going to improve. Some of the ways that it has already improved is the advent of rechargeable devices that have very, very long-lasting lives inside the body. That's an option for patients. Really excitingly is the so-called directional deep brain stimulation, something that Abbott has pioneered, and recently Boston Scientific has followed with. And essentially this is a DBS lead that allows programmers to improve the side effect profile and to improve battery life. So again, another direct patient impact technology. Also offering a more friendly experience for patients. Abbott has, for instance, an iPad and an iPod Touch as the programmer and things that we give to you afterwards. And this is a familiar technology that everybody knows how to use an iPod now, and it's just something that makes the experience a little bit more easy for patients to understand. Some of the things that's coming out in the future is that through these technologies, we'll be able to program you at home, so you don't have to go trudging into the doctor for these adjustments. So it's important that these technologies are going to get rapidly improved. The meat of this talk today is really about, like, am I a candidate for this surgery? It's really important for patients to understand where they fit in to the continuum of care and when they are a candidate for this surgery. Because again, if you get the surgery at the right time, the impact in terms of the quality of your life is going to be on the order of decades. And so to miss that opportunity is to leave quality of life on the table, which is not something that any of us want to do. So am I a candidate? What can DBS do for me? What can DBS not do for me? Remember, every therapy has its limitations. It's important for you guys to understand that going forward. A little bit about what the procedure itself looks like, and then what happens after surgery. So most importantly is, what does it take to be a candidate for DBS surgery? So with regards to Parkinson's disease, if you have one of these three things, you're a candidate. Chief and foremost is something called motor fluctuations. So what does that mean? It means it's the roller coaster that many of you basically experience as the disease progresses, and the window from when the medications work really well and when they don't go well starts to get larger and shorter. So if you remember back when you were first diagnosed with Parkinson's, when you first take a little bit of the medication, you responded so well to the meds that many people didn't even know you had Parkinson's disease. And then as the disease progresses, that nice window gets shorter and shorter and shorter. And so what happens is that patients begin to go through this horrible roller coaster throughout the day where the meds work, the meds don't work. The meds work, the meds don't work. And you're always kind of anxious about when am I going to take my next dose and things of that nature, you know? That's a fluctuation. Dyskinesias are the side effects from that medication. dyskinesias are like the writhing motions. People see Michael J. Fox on television, those uncontrollable writhing motions. That's a dyskinesia. And then finally, tremor that just doesn't respond to medication. So if you have any one of these three, you're a candidate. And if you have more than one, you're even more of a candidate. In terms of tremor, well, when you have a tremor that doesn't respond to meds and is impacting your activities of daily living, eating, dressing, socializing, you are essentially a candidate for this surgery. The workup for this surgery, I always sort of liken to sort of launching the space shuttle. There's a huge team that has to be brought to bear, and I'll talk more about the team approach later, but it's really important that you basically undergo a multidisciplinary team that will evaluate you. Chief and foremost, there'll be some behavioral testing, looking at your specific response to how you respond to levodopa. It's really important. Everybody's Parkinson's here is a little bit different than the next person's. And we want to tailor this operation to specifically treat your symptoms. This is like a patient-specific medicine. Some of you might have heard about the idea of patient-specific medicine on the internet. This therapy is a patient-specific approach. We do some tremor dystonia rating scales, videotaping. Really, really important is the Neuropsychological Evaluation, which looks at cognitive issues and non-motor symptoms of Parkinson's. These are things that are often people are struggling with, and their medications don't typically address directly. It's really important for us to bring these out, not only to minimize risk, but we can adjust the position of the electrodes to address some of these non-motor issues. And then you have to undergo a special MRI of the brain with our particular sequences so we can map your brain to place these electrodes. So in terms of what DBS can do and not do, right now there have been many 5+ year studies where patients are followed for at least 5 years. In medicine, that's an enormous period of time. Very few areas in medicine actually have studies where patients are followed for at least 5 years. And what we see is dramatic improvements in all aspects of Parkinson's disease. 70% reduction in these dyskinesias. Average patient gets a 50% reduction in how many meds they have to take throughout the day. 80% reduction in tremor, 60% reduction in the slowness, 70% reduction in the rigidity. The last two are the big impact in your life, the last two. You will see a 70% longer improvement in the best on medicated period throughout the day. So if you think about the part of the day where the meds are really actually treating you very well, we're going to increase that time by 70%. And if you conversely think about the time throughout the day where the meds really aren't helping you, we're going to take that period of the day and shorten that by 70%. So this is really what improves the quality of people's lives. Showing you some, remember what I said to you before, everybody's Parkinson's is a little different. I'm going to show you 2 different patients with Parkinson's disease and trouble with Parkinson's, and show you why deep brain stimulation can help them no matter how your Parkinson's manifests. So this is a patient with drug-induced dyskinesias. Oh.
Parkinson's disease now. You have a policy with the medicine. So yeah.
Okay, well that's not working. So you'll have to take my word for it. I'm sorry, guys. Let's try this thing. Okay, so this is a patient with bradykinesia and rigidity, slowness and stiffness.
As widely as possible.
Again, the DBS is implanted but turned off for this demonstration.
Tap with your fingers. Great, put that down. Now with the left arm, please. Open and close as wide and quickly as you can. Tap with your fingers. Okay, you can put that down. Could you put your hands across your chest and try to stand up? Okay.
Okay, shuffling of gait, partial freezing.
Okay, turn around.
Okay, you see the freezing of gait.
You're welcome. No, he's finishing his handwriting.
Okay, have a seat.
Okay, so we'll go ahead and turn on the DBS.
Okay, check this here. Okay. Okay, raise your right hand. Open and close as quickly as you can. Tap. Okay, using your left hand now. Open and close as widely and as fast as you can. Tap for me. Let me see you stand up. Okay, and let's see you walk.
Now you can see the gait's much more fluid.
Okay.
So, DBS can have profound effects on Parkinson's disease. The limitations are essentially as follows. With regards to balance and gait freezing, especially freezing of gait that happens in the face of even the best amount of medication in your body. So that's where DBS is not very good yet for dealing with that. So if you have some gait and balance issues, you're still probably going to have that even after DBS is implanted. But the other symptoms are going to be so dramatically improved that the quality of life overall is really, really, really improved. The other thing that people always ask is it neuroprotective? Does it protect me from the disease getting worse? The answer is not directly. However, one thing that Dr. Gupta alluded to is the role of exercise in terms of Parkinson's disease. Very many times as these diseases progress, the symptoms prevent you from doing the exercise. And if you can't engage in the exercise, which is neuroprotective, your disease is going to get worse. You have the surgery, many of these symptoms that are preventing you from engaging in normal exercise is now removed, and basically you can in fact have an indirect neuroprotective effect if you can intervene with deep brain stimulation early enough in the disease. In terms of tremor, the results for tremor are also very profound. For Parkinson's or essential tremor, you're about 80% reduction in tremor. MS and post-traumatic type of tremors have about a 50% reduction. I'll give you an example of a patient with tremor. So this is a sort of classic essential tremor patient. Once again, the DBS is implanted. Okay, I'm going to go ahead and turn it on. And you can see that the tremor is obviously substantially diminished. You know, people underestimate like the simple things of not being able to write your name, you know, and how that affects people's just well-being mentally and physically. It's such a simple thing that we don't consider often, many of us that are not burdened with these diseases. And this is really why I find this therapy so gratifying. So what I really hope to leave you with is this notion that DBS is not surgery of last resort. It really isn't. there have been now many studies, because again, the therapy's been around 20 plus years, almost 30 years, comparing deep brain stimulation with the best medical regimens that are available. So you take patients and half of them get the best medication that's available, the others get surgery plus a little bit of medication. And these were in some of the best journals that exist in medicine, New England Journal of Medicine, JAMA. And what they have found over and over and over again, every single one of these studies, is that the quality of life is significantly more improved in the deep brain stimulation group. In fact, I would probably say the most common thing that my patients say to me after surgery is, I've waited too long. When they see the impact on their lives and they think back, gee, I could have had this quality of life 5 years earlier, they're almost a little angry, because it's like leaving all of that quality of life on the table. And as of yet, we don't have a time machine. I wish I could, to bring people back in time, but we don't. And this is why we're here talking to you today, starting to advocate for you so that you have access to this really life-changing therapy. This is another example of what I just said to you. Essentially, the dark blue is the change in quality of life in various different areas: emotional well-being, mobility, activities of daily living, cognition, social support, for the deep brain stimulation group. And the lighter blue is what happens with just medication alone. Some of them get worse over the year when you follow them. Some are just only very mildly improved. So you can see that the differences between deep brain stimulation and the medication group, it's profound.
Do you have to be at a certain level of PD to have surgery?
As long as you have one of those essentially 3 issues, either tremor that doesn't respond well to meds, or if you're noticing that the medication window is becoming problematic, or if you're having some dyskinesias, you're a candidate.
It's not for like beginning of Parkinson's.
Well, it's not for like meaning newly diagnosed. No, it's not typically given to patients that are newly diagnosed, although that's a good question. There are actually trials that are going on recruiting for the newly diagnosed, because we would like to know what happens if you never really get to that point. What is that impact in terms of the quality of your life and what Parkinson's does over time? So people are looking into that.
Yeah, because they can have all the symptoms of rigidness, stiffness, and memory, the biggest issue, and not a tremor.
Yes, tremors.
But memory is still a big issue.
I would say the most of the patients that I'm operating on now are issues regarding those fluctuations rather than tremor per se. The surgery itself is generally done in 2 stages. The first stage is placement of the deep brain stimulation electrodes into the brain targets, and the second part is the implantation of the pacemaker unit itself. Chief and foremost of the way I do deep brain stimulation surgery, and the way many still do it, is the placement of this something called a stereotactic head frame. It looks medieval, but it allows you to hit these millimetric targets with really, really fine precision. And I always liken another analogy that I like to explain to patients. Hitting these targets is like being in Earth orbit and having to hit home plate at Yankee Stadium with a baseball. So you need like this technology to really precisely get it in the right place. Because, again, another analogy, DBS is like real estate. Everything's about location, 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 right? You've heard that about real estate? And if you happen to own a donut store and you open up next to a police station, that might be a good place for that donut shop, And so again, location. And the thing is that it's really important that if you don't get these electrodes in the right place, you're not going to see the kind of side effects that you see over here. One of the aspects of my practice is I end up revising leads that have been implanted not only in the tri-state area, but around the country. They come to me because they're implanted in centers that are not as experienced as ours. The leads are not well placed, and we end up having to move them in order to get the best results. You have a question?
How many have you done?
I've done upwards of 1,500. More than 1,500, but I'm not exactly sure at this point. I stopped counting at 1,000 with the notion that if you can't get something right, doing it 1,000 times, you probably shouldn't do it anymore. And it's a good question, and we will get to that later on. Location, location, location. There are 3 typical targets for movement disorders. Each one of them can address different aspects of the disease. And one of the things that our center is really good at is looking at your specific constellation of symptoms and figuring out a target-specific approach for you, not treating every patient exactly the same. We place the head frame. It's usually done under sedation. It takes about 15 minutes. And then we get a CT scan. And again, it looks medieval, but we keep you smiling throughout the process. Okay. Now, historically speaking, the classic deep brain stimulation implantation procedure involved a process called microelectrode recording, which is a use of a very fine electrode that's inserted into the brain that forms like an electrical map of the brain. And this was typically done awake. And you might be thinking like, what? Awake brain surgery? That's weird. I mean, that's really weird, right? Well, it turns out that these electrical signals that are behind your Parkinson's or dystonia or essential tremor don't exist in the sleeping state. So we needed to actually keep you awake to hear these electrical signals. But the funny thing about the brain, even though the brain is the organ which we use to feel the world around us, the brain itself is the one organ in your body that has no pain receptors. It can't feel any pain in of itself. So after the scalp and the first very thin layer of skull, you actually have no pain receptors anymore. It's really rather remarkable. So you actually will not feel any pain during a surgery if you were to have the surgery done awake. This is an example of some of the electrical signals that we can record in the brain, and then the electrode then goes into the brain, and you can see a mock-up of the subthalamic nucleus, and this is sort of the way the electrode looks like in the thing. We then typically tested the DBS electrode, not just to look for clinical benefits. We're not looking for your Parkinson's to go away right on the table, because that's a little bit longer process that happens after the surgery is done. We look for side effects that gives us an idea of where the lead is placed. Then, as an outpatient, you have the battery packs placed. They're typically placed in the upper chest region, and then the leads are then attached with an extension lead from the battery pack all the way up to the brain leads. People always wonder, how do you get the leads down from here to here? It's like if any of you have ever had to pass wire behind drywall, it's the same process. You place a conduit around the skin, and then you can thread the electrode down, and it's the same process that we use passing cable in your house, believe it or not. Here's the important thing to remember now. Sleep versus awake surgery. So the good news is that the awake surgery era is rapidly coming to an end. Why did we do awake surgery in the first place? Because the images of your brain that we typically had in years past wasn't good enough to get the electrode exactly where we wanted to go. And so we had to supplement the poor images with another signal, and that was the electrical signals. That's why we did it. It wasn't because we wanted to be Dr. Frankenstein. It was because it was the best we had. The good news is that imaging has evolved, and now we can see these targets really well. So well that I think many of you in this audience are going to be able to see the targets where we weren't able to before. So these are the MRIs that we had of years past, and you can kind of see these dark areas vaguely over here. Those are the target areas for deep brain stimulation. A little dark area over here. Again, these are areas that we typically place the electrode. This is a sequence that I've developed along with some researchers in Cornell University. And now, what was very vague to be seen before, I think most people here in the audience can see these bright white areas that are very, very distinct. The fact that we can see it so well now makes it so that we don't have to keep you awake in the operating room if that is your barrier to undergo the surgery. Yes? You can, but with just a pure CT scan, you're then relying on the microelectrode recording. The CT scan does not show any of these targets at all. And I've done it under pure CT for patients that have had older pacemakers. I've been able, especially for tremor, we were able to do the mapping and so on. So you can use various forms of intraoperative imaging to take advantage of these new sequences of MRI so that patients can be completely asleep. And either interventional CAT scan, which is a fusion of CAT scan and MRI, or just MRI alone. And again, it allows an asleep DBS lead placement as the clinical situation warrants. If your only barrier to getting this surgery is that you're so afraid of undergoing awake brain surgery, that no longer has to be a barrier. You can be asleep if you feel it's necessary. Another technology that patients have been sort of introduced to over the last year or two is something called focus ultrasound. How many of you have heard of focus ultrasound? Couple? Okay, fine. So focus ultrasound is a really nifty new technology. It essentially allows us to burn a tiny hole in the brain using just sound waves. So we don't have to make an incision in your scalp. There's no hole drilled in your skull. But with sound, we can burn a tiny hole in the brain. Now you must be thinking, why do I want a hole in my brain? Well, it turns out, long before we had deep brain stimulation, that's how we modulated brain function. We would go to these very same targets, and using probes, we would map it out, find the target, and then we would burn a tiny little hole with radio frequency, which is the kind of energy that your microwave uses. And it turns out that making these tiny little holes really does help a lot of these symptoms. So it's not that it wasn't efficacious, but it lacked two aspects of deep brain stimulation that really is a big advantage of the DBS approach over these lesions. One, you can't program it. So if your disease changes over time, deep brain stimulation has a battery pack. We can actually change the parameters of the stimulation, and we can adjust the stimulation according to the way your disease changes. A lesion in the brain, a tiny little hole, stays a little tiny hole. So if your disease changes, there's not much you can do about it. Secondly, if you have side effects from making a hole, you have to live with it. There is nothing you can do about a side effect due to a lesional procedure. You have to live with it. DBS can be programmed where we can minimize that, especially with the new technology of leads that are coming out. We can minimize these side effects. So this was first published in 2013. There have been a small number of patients treated. It's great, yeah, no hole in the head. But we really only know short-term follow-up right now. Right now, we only have studies that follow these patients now for about a year. So we don't really know what happens 5 years out, 10 years out. We do know with DBS we do. And the risks are similar to deep brain stimulation. The other limitation is that you really can't do these procedures on both sides of the brain. So that means you have to kind of pick one half of your body to treat, and the other half can't be treated. And we know this because when you burn holes on both sides of the brain, there are a lot of extra side effects that you don't have with stimulation on both sides of the brain. What are the complications? Look, it's a surgery. And I think it's really important when considering a surgery, you really should know the complication rate and be at peace with it, right? If a doctor ever tells you, oh, no side effects, or, oh, there's no chance of any complication, run from that person. Because look, it is surgery. If you look at the published literature of about 150,000 DBS patients worldwide, and that's growing every year, there's about a hemorrhage rate of about 3%, an infection rate of about 4 to 5%, And then there's hardware-related complications like the leads fracturing or the devices eroding through the skin at about 6%. People often read about the effect of DBS on speech, and it's very variable. It's more likely to happen in patients that have pre-existing speech issues. DBS in of itself doesn't cause speech problems unless there is a lead that's generally not placed well, or if a patient has a severe speech issue going into surgery. I have had over 1,500 implants. My complication rate is significantly lower than the average in the literature. I think that's a reflection of how many I've done over the years, and the fact that this is 90% of my practice. Many of these neurosurgeons that do it, they maybe do once a month, maybe once or twice a year in some cases. I do this 3-4 times a week, week in and week out. So I believe that experience helps me reduce the complication rate. What happens after surgery? Programming. Dr. Gupta works her magic along with nurse practitioners to program these devices. It's really important to understand that it takes weeks, sometimes months in the case of dystonia, to get the best effects. This is about gently bringing the brain back to a more normal state. So there has to be patience. And then Dr. Gupta already recognized this and mentioned this, lifestyle management, getting you back into an exercise program is so important. So I'll just leave you with this. Why our team? Allow me to just sort of give a plug for the amazing people that I have the privilege to work with. Experience counts. This has actually been studied in a scientific study. They look at how much experience a center has and what their complication and efficacy rates are. And what they found is essentially the number of cases is directly tied to overall success for patient selection, to minimize the complications, and to maximize the benefits. Together, there is no center in the tri-state area, because Mount Sinai has been doing this since the late 90s, that has nearly the same man-year experience in terms of deep brain stimulation than any other place in the tri-state area. We have this multidisciplinary approach. So many specialists come together, and every one of you that pass through our ranks are touched in some way, either indirectly or directly, by our specialists. When you come to see us, it's not 1 or 2 doctors that are going to be taking care of you. You're going to have this enormous team with all of this expertise brought to bear to specifically tune this circuit that's going wrong in your brain so that we give you the best results. The other really nice thing about Sinai is that it's an academic medical center. And so what does that mean? Well, obviously your care is our #1 concern, but we also have a mandate to improve the field, to push the ball of knowledge down the road. And so you will have an opportunity to participate in what I think are exciting clinical studies. And so you will not only help us expand our knowledge, but by having your care with us, you're a part of helping the effort to make a cure for these terrible diseases. So in conclusion, I really do hope to leave you with this notion that this is not surgery of last resort. The efficacy and safety of DBS supports its use in very, very much earlier stage than people typically understand. And that there is a clear advantage of DBS over medical management alone in terms of your quality of life. And that the operation itself has really evolved and continues to evolve with better patient selection, image guidance, shorter OR times, and much less risk and much more comfort for you. So now, that's the end of my talk. I hope this was helpful.